Bismillahirrahmanirrahim. Welcome to ERA, Easy Radiology Approach. Our second part of MRI of the epilepsy we will discuss today. I am Dr. Muhammad Talat, Assistant Professor of Radiology, Cairo University. As we discussed before, that the main cause of epilepsy is the temporal lobe epilepsy, and this is the main point that we will focus today. We have other causes of epilepsy, and these causes we will discuss this one in the part 3 of MRI of epilepsy. And we are reminding ourselves, don't miss post-ictal changes. As we discussed before, that the temporal lobe epilepsy, we have two types, mesial temporal lobe epilepsy affecting the medial aspect of the temporal lobe, and we have also lateral temporal lobe epilepsy. This one is affecting the outer part of the temporal lobe. Regarding the mesial temporal lobe epilepsy, the main cause for this one is the mesial temporal sclerosis. This is the most common, and sometimes we call it hippocampal sclerosis. We have also subtype of the mesial temporal lobe epilepsy manifested by enlargement of the amygdala and high signal of the amygdala. In some cases, we have dual pathology. For example, we have mesial temporal sclerosis and cortical malformation. Both of these abnormalities can present or can explain the epilepsy in the patient. This dual pathology accounts not more than 15%. Sometimes the pathology or the mesial temporal sclerosis can be happened bilaterally, and this is one of the challenging point in diagnosing of temporal lobe epilepsy, because unilateral pathology, it's easy to identify, easy to pick up, because we are comparing the right side to the left side. But if we have bilateral pathology, sometimes it is difficult to identify. So take care of this point. Mesial temporal sclerosis, we have multiple primary imaging features of hippocampal sclerosis. The first point is loss of the normal architecture. As we discussed in the first part, the normal hippocampus shows serrated outline or interdigitating form. Once we have paucity of these digitations or flattened hippocampus, this is one of the imaging features and highly specific for mesial temporal sclerosis. Also, if we are scanning the patient in higher MR scanner, sometimes we can detect some striations in the hippocampus, alternating gray and dark lines in the hippocampus head, especially. But if we have loss of this normal striation, it is considered one of the imaging features of mesial temporal sclerosis. Also, if we have gliosis of the hippocampus, this can display high signal intensity in T2 and FLAIR images. Of course, if we have atrophy or volume loss of the temporal lobe or hippocampus specifically, if we have any atrophic changes, any volume loss of the hippocampus, this is considered one of the imaging features of the hippocampus. The last point is that we can identify mesial temporal sclerosis if we have malrotation. We discussed in the first part that the hippocampus normally has horizontal orientation, parallel to the temporal horn superiorly, and also parallel to the collateral sulcus inferiorly. But once we have vertical orientation of the hippocampus, or the hippocampus appears as a clumped or rounded structure, this is considered abnormal, and we can take this one to diagnose mesial temporal sclerosis. Sometimes, if we have malrotation of the hippocampus, sometimes we have vertical collateral sulcus as well. Also, we have secondary imaging features for mesial temporal sclerosis. In the logic thinking that if we have volume loss of the hippocampus, the adjacent structures will take the place. So first we have dilatation of the temporal horn, one of the secondary imaging features. widening of the collateral sulcus. All of these features secondary to volume loss of the hippocampus. We have also atrophy for the ipsilateral parahippocampal gyrus, anterior thalamus, fornix, and mammillary body. Of course, all of these are structures related to the limbic system. Once the hippocampal head or the hippocampus start to be atrophied, the other parts of the limbic system secondary will be atrophied. Also, sometimes we have high signal or atrophy of the amygdala. Of course, amygdala part of the limbic system as well. Let's move to our cases for today. Let us start by this case. Look for the right side here. The right side, this is the hippocampal head at the level of the mammillary bodies. So this one is preserving its digitation. This is the normal appearance of the hippocampal head. Look for the another side, contralateral side. Look for the hippocampus here. There is for little bit digitation, but there is for little bit paucity of the digitation. If we are using higher MRI scanners, you will see some stratification in the right side of the hippocampus, the normal side. The left side, there is a loss of striation. We have also secondary signs in this case for some hippocampal atrophy. We have the temporal horn. Look for this one and this one. The left side, for sure, dilated as compared to the right side. So we have indeed findings suggesting of left side mesial temporal sclerosis. Let's go to my second case for today. Look for the right hippocampus. This one, as we compare it to the left side, the right side or the right hippocampus appears rounded, clumped. There is a loss of the normal architecture for the hippocampus. There is a high signal, that means there is gliosis of the hippocampus. So it is totally different than the normal side on the contralateral side. Really, we don't have too much secondary sign except minimal dilatation for the temporal horn as compared to the left side. We don't have any other manifestations of volume loss. The parahippocampal gyrus is normal. Fusiform gyrus is normal. Even the collateral sulcus also normal. We don't have any other signs of volume loss. Even we have the fornices, the left side and the right side is normal. We don't have any more secondary signs of hippocampal sclerosis. But let us move and see the rest of the brain. There is a surprise here. What is this? This patchy area taking the U-shaped fiber of the white matter at the right temporal gyri, displaying high signal intensity in FLAIR image. There is no significant mass effect, no significant cortical thickening. In our routine practice, we can think of focal cortical dysplasia because this case is complaining of epileptic fits. The another differential diagnosis is low-grade glioma. But really, when we start to move to see the rest of the brain, you will find multiple patchy areas similar to this one. Look for this area. left temporal side. Also, we have patch area of altered signal intensity. We have here multiple foci of altered signal intensity in the white matter. So, in the logic thinking, in a case of epilepsy, may this represents hamartomas in the brain, may be demyelinating. So, the differential diagnosis will be too much different. So, indeed, we are sure that we have right side mesial temporal sclerosis, and we have multiple findings in the white matter, maybe demyelinating, maybe hamartomatous. This one needs to be correlated with the EEG findings and needs to be correlated with the clinical findings if there is any other manifestations of neurocutaneous disorders or something like this, and the follow-up will be much helpful in this case. Our last case today, this patient is an old patient. He presents by recent onset of epileptic fits. And after reviewing the case, we discovered that the patient did an operation on the left side. We have here left side craniotomy flap. That means the patient did an operation before. Really, we don't have complete history for the patient. If there is any abscess here or infection, maybe something neoplastic. We don't have really exact history for the patient. But we have here the patient has recent onset of epileptic fits. So let's go to see the coronal image. Look for the right side. Let's start by the normal side. This is the hippocampus. It preserves its normal digitating form. Maybe the temporal horn is slightly dilated, but I think it is apart from whole ventricular dilatation of the patient. Look for the third ventricle and postlateral ventricles are dilated as well. Let's go and focus on the hippocampus again. So we have here on the right side, the hippocampal is preserving its volume, its shape, its morphology, its signal. Let's go to the left side. The hippocampus, there is marked distortion of the hippocampus. The morphology is lost, the volume is lost. High signal. This high signal of the hippocampus is continuous with the high signal in the left temporal gyri. So this one is left-sided encephalomalacia, area of encephalomalacia involving the left temporal gyri, involving the fusiform gyrus, involving the parahippocampal gyrus, involving the hippocampus itself, even the amygdala. If we have here, this is normal amygdala. This is abnormal amygdala. The amygdala is almost lost. So indeed, this patient did an operation before, and recently he complained of new onset of epileptic fits. So according to the history and according to the radiological findings, we have a case of left-sided mesial temporal sclerosis, but this one is considered as a secondary. Left side mesial temporal sclerosis secondary to area of gliosis involving the left temporal lobe. In this case, we should also see the fornix almost normal. The mammillary bodies almost normal. So we don't have any atrophic changes in this part of limbic system. Thank you so much for attending this lecture, and we are waiting you in the third part.